Good morning, everyone, and this is a short lecture about post-operative complications. And in this one, of course, there is a lot of post-operative complications, ranging from hemorrhage, fever, and seroma formation, damage to the adjoining structures, and things like this, wound dehiscence, and many post-operative complications are there. But in this lecture, specifically, what we are going to discuss is basically post-operative pulmonary complications. Okay, so uh, first of all, I'm going to talk about a list of post-operative pulmonary complications. What are they? Okay, so pulmonary complications. Okay, so there are many post-operative pulmonary complications which can occur. Out of them, some of them they are here. Like one of the thing is called as atelectasis. There could be pneumonia. Okay, other than that, other than this atelectasis and pneumonia, there could be aspiration, pneumonitis. Okay, there could be because of that abscess formation can occur as well, like because of pneumonia. There could be pulmonary edema. There could be acute lung injury. There could be uh, adult respiratory distress syndrome. Other than that, there could be pulmonary embolism. There could be venous like DVT and pulmonary embolism. They are same conditions. See, there is a lot of complications you can say. Okay, I name few of them here over here. So what, like, this is a short lecture, you can say. Actually, um, what they do is like with shock, they have included the small topic of postoperative pulmonary complications. So don't worry, we will study other pulmonary complications or other surgical complications as well. But in this lecture, we are going to discuss purely the pulmonary complications. Okay, why this thing is important? Because one of the thing which I wanted to mention over here is what, before any surgery, the pulmonary status of the patient is very important, and that's the reason they ask the patient to quit smoking, and they do a chest X-ray as well to minimize these kind of complications. So you can say the physiology or the a normal physiology of the pulmonary system is very important for a successful surgery. And there are many risk factors. For example, like whenever they operate on abdomen, for example, so due to pain, the patient, they cannot um, uh, breathe properly, and because of that, um, it can lead to atelectasis, it can lead to pneumonia. uh, there are many risk factors like obesity, smoking history, someone who has COPD. All these things can lead to multiple uh, pulmonary complications simply. Like in physiology, you have covered what you can say the pulmonary function test, and if you know what is vital capacity, the vital capacity can be reduced up to 50% for the first 2 days after surgery. Okay, there are many factors behind that, like the effect of the anesthetic drugs, narcotics, um, and many more, which basically interfere with the respiratory drive of the patient. So, in internal medicine, you will also study respiratory failure. What is type 1? What is type 2? Okay. So, that's one of the reason, before the surgery, the anesthetics, they take the anesthesia fitness and they evaluate the patient. They take the history of smoking, either they are able to walk, either they have any respiratory conditions beforehand, either they use any drugs, either they use any inhalers, and then they take a chest X-ray. Sometimes, if the surgery is too extensive, they can do a ABGs, they can do a spirometry, or simply lung function test. Okay, just to see either the patient is fit for the surgery or not. So, among some of the complications, like to start with, there is atelectasis. Now, what is atelectasis? Basically, is It is the most common post-operative respiratory complication. So what happens is atelectasis is basically defined as like uh, there is a collapse of the alveoli. Okay. Um, because now what happens is due to secretions which the patient cannot clear after surgery, what happens like the secretion can build up and they can block the small airways. They can make the alveoli to collapse. Okay. So you can see like there's a lot of predisposing factors like smoking, pulmonary problems like any conditions, anesthesia, drugs, depressed cough reflex, and nasogastric tube can also lead to and congestion of the bronchial walls. Okay. Uh, Now, atelectasis occurs basically in the first 24 hours post-op, and the patient they present with fever, tachycardia, uh, rales, okay, and it can lead to pneumonia as well or the formation of lung abscess. You can see over here, sorry, this one. This is a um, patient who have atelectasis. Okay, this is how like the chest X-ray is quite normal. So 90% post-operative pulmonary complication. 90% of the complication, atelectasis is the most common, is the first one to develop. So again, like this is the etiology which I already talked about. Like there is obstruction due to secretions or there is hypoventilation. So now, how we treat atelectasis is by if you'll ask the patient not to smoke um, before surgery, at least 2 weeks is the minimal time. So, or if there is if they have any pre-operative lung or lung disease or lung condition, of course, if we can treat that, they're going to decrease the chances of atelectasis too much. Minimal use of depressant drugs, prevent pain, early ambulation, change body positions, deep breathing and coughing exercises. Drugs, we can give them expectorants, mucolytics, and bronchodilators. All of these can decrease the chances of atelectasis. Other than that, due to anesthesia, because the cuff reflex is depressed, if something will go, because the cuff reflex is not there, so for example, anything which was in the tummy or anything from the mouth can go into the lungs, can lead into pulmonary aspiration. And that's the thing, whenever they operate on any patient, they ask the patient to not to eat anything at least 8 hours before surgery because they don't want anything in the abdomen, in the gastric area, because during the surgery, because the things can regurgitate and can go into the lungs. So see, the prevention is nothing but oral 6 hours prior to surgery. In case of emergency, whenever they have to perform emergency surgery, what they do, like they do a gastric lavage, they clean up all the things inside the tummy. Any patient who have pulmonary aspiration, so what is the treatment? Again, they can give them mechanical ventilation with antibiotics. So this is one of the thing. And okay, there's one thing called as aspiration pneumonitis. So what is aspiration pneumonitis? It's basically aspiration of the oropharyngeal or gastric contents into the respiratory tract. Okay, and it is a serious complication of surgery. So aspiration pneumonitis is also called as Mendelian syndrome. So what it is basically acute lung injury that results from the inhalation of regurgitated gastric contents. Whereas aspiration pneumonia, okay, aspiration pneumonia results of the inhalation of oropharyngeal secretions, right? So remember, they are full of bacteria. Okay. So that's why the fasting is important That's why gastric washing is important before surgery. If it's done in the emergency, or gastric emptying is important, okay, in these patients. Or that's why nasogastric suctioning is important. So anyhow, who have done this thing, like normally before surgery is what they ask the patient to not to take anything orally at least 6 to 8 hours before surgery, okay, or don't drink anything in case of fluids, for diabetics, this period is prolonged because in diabetics, the gastric empty is reduced, their gastric motility is not so good. Sometimes they do give the patient PPIs, proton pump inhibitors, omeprazole, drugs like this, like to decrease the acid secretion. When there is less acid secretion, of course, like there is less risk of chemical pneumonitis. Then comes the pulmonary edema, and the etiology is circulatory overload. When someone is infused too much with the fluids, left ventricular failure, of course, it can lead to pulmonary edema or negative pressure in the air. So anyone who have pulmonary edema, of course, I'm not discussing this again in too much detail because in internal medicine you are going to discuss a study about pulmonary edema in detail, how we treat that, or you are going to we are okay, and we will be discussing ARDS in detail. That's why I'm not going in detail of that. But again, I have to enumerate over here because it's one of the complication. But remember, whenever anyone have pulmonary edema, or for example someone have ARDS, what are the things we do? Uh, we take the chest radiograph to diagnose. We put the patient with catheters. We check the vitals of the patient. We check the VBGs, or what you can say atrial blood gases or venous blood gases in emergency. And of course, like the treatment is simply to put the patient or these patient on um, mechanical ventilation. Okay. In pulmonary edema, we can give them with Lasix, like the diuretic drugs. We give them with like painkillers and drugs like this. So that's how we treat this thing. Respiratory failure, again, there are two types, type 1, type 2, and this one you are going to study in great detail in internal medicine. Okay, so one of the thing which can occur uh, is pulmonary embolism. Now, pulmonary embolism, again, you will study in internal medicine in detail. Pulmonary embolism and deep venous thrombosis, they are considered as same condition. And many of the patients, they may develop DVT or venous thromboembolism or pulmonary embolism as a result of some surgery, especially on the lower in the pelvic region, especially in the lower tummy, especially when they have cancers, or when there is like prolonged immobilization. Um, Versostride, like if you remember, what is that? Like they have like hypercoagulable state, or some people who are already having thrombophilias. What happens is like there is a clot formation in the deep veins of the leg, and that clot can start traveling and can reach to the lungs, and they can block any. It could be like depending on the size of the clot, they can block a big vessel in the lungs, or they can block a small vessel in the lung, and due to that the patient will having started having the signs and symptoms of pulmonary embolism, uh, which could be pleuritic chest pain, sudden dyspnea, tachypnea, hemostasis, tachycardia, presence of the fourth heart sound, or the loud S2. So anything of these things can occur. So anyhow, like anyone, whenever we are suspecting someone who is having pulmonary embolism, so what can be done for these patients? What can be done? Of course, like to diagnose, what we do, we can do go for a chest X-ray. We can check the D dimers. We can check the clotting profile. We can send the patient for VQ scanning or CT pulmonary angiogram, which is the gold standard in this case. You can also do a ECG. Okay, and based on these things, whenever the pulmonary embolism is diagnosed, depending on the condition of the patient, if they have the like dropping blood pressure or things like this, we can go for clot buster therapy, or we can put the patient on heparin, for example, or low molecular weight heparin can be given. But again, how we can prevent this thing? This thing is important. Like this can be prevented simply by uh, early mobilization after surgery, or you can say before surgery if the patient is high risk. So what can be done? Like we can put the patient after surgery uh, on some drugs. Okay, like we can give prophylactic medication to prevent any thrombus formation in these patients. So anyhow, like these are all the pulmonary complications which I enumerate them, and don't think like I went too fast in this case, but like there will be a lecture on post-operative complications. Okay, there like this one will be covered in internal medicine, ARDS and acute lung injury. All these things we are going to cover again in surgery. Pulmonary edema, all these topics will be covered in great detail in internal medicine. So this is you can say like this is um, just enumeration of all the post-operative pulmonary complications. So thank you so much for listening. I hope you understand. I will see you around.